What a fantabulous evening, my dear friends, pulmonologists, physicians across the subcontinent. Good evening, one and all. This is Dr Vijay Kumar Chennamchetty, senior pulmonologist and lead intervention pulmonologist from Apollo Jubilee Hills, Hyderabad. And also, I'm the webinar coordinator for Chest Council of India. Today, next 1.5 to 2 hours, we'll have a talk on sleep disorder breathing by Dr. Jayaraman from Chennai. Welcome, Dr. Jayaraman. And followed by panel discussion. Whatever queries you have, please do mention in the question link. We'll be happy to take after Dr. Jayaraman's talk. Dr. Jayaraman is a good friend of mine and was colleague to me at Apollo Chennai. Welcome, Dr. Jayaraman. Next, we have other stalwarts with us. Dr. Shivani Swami. She is joining us from Jaipur, senior consultant, and was one of the leading sleep medicine consultant from Jaipur. Welcome, Dr. Shivani.
Thank you very much for having me here. Good evening, everybody.
Next, I would like to call upon Dr. Kripesh Ranjan Sharma, senior pulmonologist and sleep disorder specialist from Guwahati Apollo Hospitals. Welcome, Dr. Kripesh. Dr. Ajay Godse is another good friend of mine from Mumbai. He's also a pulmonologist and sleep disorder specialist, currently working with BHRI Mumbai. Welcome, Dr. Ajay.
Good evening, everybody. Thank you.
And we have to cover the surgical aspects of sleep medicine, particularly sleep disordered breathing and obstructive sleep apnea. We have Dr. Srivatsa from Chennai, intervention fellow of Piri Furchard. He is the current director of Ammanana Dento from Chennai. He is a consultant maxillofacial surgeon as well. Welcome, Dr. Srivatsa. And last but more important, Dr. Vikas Agarwal is joining us from Mumbai. He is chairman of Committee for Sleep Disorders, Indian Academy of Otolaryngology and Head and Neck Surgery, currently director of Specialty ENT Hospital from Mumbai. Welcome, Dr. Vikas.
Thank you, Dr. Vijay.
And here I'm absolutely delighted to moderate this session. Thank you, Dr. Krishna Anna, for having me here as a moderator on this evening session on World Sleep Day. This time, World Sleep Day slogan or theme is quality sleep, sound mind, and happy world. So when we look back ourselves, probably 2 to 3 decades back, probably we were all in our childhood where this much busy lifestyle was not there. I'm sure sunrise means we all used to wake up. Sunset means we'll tune ourselves to sleep mode. But with this rapid westernization of lifestyle, what has happened is in the past 2 decades, there's a lot of habits like boozing, pop culture, excessive stress at work, and a lot of consuming of neurostimulants in the form of coffee, caffeine, theophylline, or other soft drinks. This is leading to a lot of sleep disturbances and a lot of health related problems. So we are in rat race. What for this rat race? Is it really, that much essential? Is it more important to our health? Not at all. So with this short intro, I would love to request Dr. Jayaraman to talk on overview of sleep disordered breathing. Over to you, Jayaraman.
Thank you, sir. Namaste, very good evening. I am Dr. S Jayaraman, consultant pulmonologist from Chennai. Today is the World Sleep Day. To commemorate this day, CCI, Chest Council of India, is doing this wonderful webinar on sleep disordered breathing. So today is another important day for us is the Holi Day. Wish you all happy Holi. Festival of colors, festival of love, festival of spring, filling life with colors of joy. World Sleep Day every year. This is hosted by World Sleep Society in the month of March. This year, 2022, the theme of this World Sleep Day is Quality Sleep, Sound Mind, Happy World. What is this definition of quality sleep? This is a good sleep by definition. Sleep during sleep without any break, continuous uninterrupted sleep. If you wake up in the morning, you feel fresh, active, energetic. This is the good sleep, quality sleep, which leads to sound mind and a happy world, will do a lot of wonders. This is the basis of this World Sleep Day. Today, we'll be describing about the sleep disordered breathing. We respiratory physician, this kind of a sleep disordered breathing is the common practice we come across left and right. Sleep disorder breathing is a spectrum of disorder characterized by snoring, upper airway resistance syndrome, obesity hyperventilation syndrome or Pickwickian syndrome, obstructive sleep apnea, and hypoapnea syndrome. Sleep disordered breathing is a common among the sleep disorders. Among the sleep disorder breathing, sleep apnea, in obstructive sleep apnea is a commonest practice we come across as a respiratory physician. In general, the sleep disorder breathing is a under-recognized, under-diagnosed, under-treated condition. To start with the spectrum of disorder, the first is snoring. Snoring, what is snoring? Snoring is an abnormal respiratory sound during sleep. If you ask any layman about the snoring in sleep, they say, yeah, good sleep. So we know as a doctor point of view, this is a very bad sleep. Snoring is a struggling to breathe. So abnormal respiratory sound during sleep due to turbulence of airflow in a narrowed airway because of vibrations from the upper airway wall. There are two kinds of snoring. Simple snoring. This will be due to cold, allergy, infection. This will be there for maximum 3 to 5 days time. This is self-limiting. So with the medication it will go. But in the case of habitual snoring, any patient is having a daily snoring. This is sleep apnea snoring due to passage of breathing. Breathing passages narrows while sleeping and produce complete blockage of upper airway. Upper airway resistance syndrome. This is another spectrum of sleep disorder breathing. The common points are excessive daytime sleepiness. These patients having excessive daytime sleepiness, sleep fragments with or without snoring, without oxygen desaturation. Upper airway resistance syndrome, UARS, respiratory effort related arousal due to upper airway resistance with no oxygen desaturation. If you do this sleep study, so you won't find any apnea hypopnea score more than 5. There's a positivity. But because this is a forerunner of obstructive sleep apnea, so it will treat effectively in these conditions. Other spectrum of sleep disorder breathing is the obesity hyperventilation syndrome or Pickwickian syndrome. The characteristic findings are morbid obesity, BMI, body mass index more than 40 kilograms per meter square, chronic hyperventilation with hypercapnia, PaCO2 more than 45 millimeter of mercury during wakefulness, nocturnal hyperventilation with at least 10 millimeter of mercury increment in PaCO2 during sleep. frequently coexist with obstructive sleep apnea, overlap syndrome. Coming to the obstructive sleep apnea. What are obstructive sleep apnea and obstructive sleep apnea syndrome? OSA or OSAS are subsets of sleep disorder breathing. Obstructive sleep apnea is the occurrence of an average 5 or more episodes of obstructive respiratory events, apneas, hypopneas, or RERAs, respiratory events related arousal per hour of sleep with either sleep-related symptoms or comorbidities, or 15 such episodes without any sleep-related symptoms or comorbidities. OSAS is defined as obstructive sleep apnea associated with daytime symptoms, most often excessive sleepiness. This is the guidelines from the Indian OSA guidelines. By definition, obstructive sleep apnea is a recurrent episodes of partial or complete airway obstruction during sleep due to repetitive collapse of the pharynx, necessitating recurrent awakenings to re-establish airway patency. There are two main events in obstructive sleep apnea. One is hypoapnea. By definition, more than 50% reduction in airflow for more than 10 seconds or less than 50% reduction in airflow plus 3% oxygen desaturation plus or minus arousal. Apnea means total cessation of airflow for at least 10 seconds. These are all the factors potentially modulating the clinical phenotype in obstructive sleep apnea. You all know well, obstructive sleep apnea is a complex disease. So there are so many factors influence the phenotype, clinical presentation phenotype. One is the hereditary traits regulating upper airway structure, hereditary traits regulating facial structure, hereditary traits regulating ventilator sensitivity, nutrition, coffee, obesity, exercise, alcohol, air pollution, smoking, work schedule. These are the influential factor which leads to there are several phenotypes, mainly the 6 clinical presentation phenotypes of obstructive sleep apnea. REM-related apneas, rapid eye movement related apneas, obesity-related apnea, position-dependent apnea, apnea with hypersomnolence, complex apnea, asymptomatic apnea. There are 3 clusters of obstructive sleep apnea presentation. One is a disturbed sleep group, other one is minimally symptomatic group, other one is excessive daytime sleepiness group. The dose of while driving is one of the important risk factors associated with the driver. Fall asleep involuntarily, fall asleep if relaxed, wake up with a headache, wake up suddenly and cannot breathe, snore and disturb spouse sleep, breathe pauses at night, restless during sleep, perspire heavily during the night, wake up often during night, wake up too early, have difficulties falling asleep at night. These are the various clusters of clinical presentation of obstructive sleep apnea. This is the pathophysiologic mechanisms and consequences of obstructive sleep apnea. There are 2 events, apnea, hypopnea, which leads to sleep fragmentation, hypoxemia, negative intrathoracic pressure, which eventually leads to sympathetic surge that release catecholamines from the adrenal gland, and hemodynamic effects on cardiovascular system, oxidative stress, inflammation, endothelial dysfunction, hypercoagulability, endocrine dysfunction, which eventually leads to cardiovascular diseases like hypertension, coronary artery disease, congestive heart failure, arrhythmias, cerebrovascular accident, pulmonary hypertension. These affect over the endocrine gland, mainly causes endocrinopathy, diabetes mellitus, insulin resistance. The sleep fragmentation directly leads to sleepiness, which leads to crashes, poor quality of life. And the sleep fragmentation, which leads to neurocognitive effect, poor cognitive function, poor executive function, poor quality of life. Conditions in which sleep apnea should be suspected. These are the common clinical conditions we come across in our practice, whether we are a chest physician or as a gynecologist or a surgeon, general physician, whichever the field. These are the common clinical conditions in day-to-day practice. Systemic hypertension. Any patients with a single drug therapy or dual drug or triple drug therapy with uncontrolled hypertension, one of the comorbid condition, a secondary cause of hypertension is the obstructive sleep apnea. Obesity. 80% cause of OSA is obesity. Myocardial infarction and cerebrovascular accident, CVA, one of the important comorbid condition is the obstructive sleep apnea. Pulmonary hypertension. The secondary causes of pulmonary hypertension, one of the treatable EC cause is the obstructive sleep apnea. Type 2 diabetes mellitus in India. This is one of the common disease. Diabetes is one of the world capital. India is a world capital, and every diabetic patient, any fluctuating sugar level or uncontrolled diabetes, one of the common comorbid clinical condition is the obstructive sleep apnea. Nocturnal cardiac arrhythmias is one of the potent factor in which patient died suddenly during sleep. It's one of the causes because arrhythmia due to the hypoxia. Driver involved in a sleep-related automobile crash is a very important etiology behind road traffic accident. Pre-operative anesthesia evaluation is important for anesthetist and surgeon. Uncontrolled asthma. There are several comorbid conditions which leads to uncontrolled asthma like sinusitis, GARD. The obesity and obstructive sleep apnea plays a major role in cause of uncontrolled asthma. Cancer, because of the intermittent hypoxia, which leads to oncogenesis, or the theory behind the cancer formation from head to foot. How to diagnose obstructive sleep apnea clinically? So diagnosis is based on the clinical history. So commonly we use the stop band questionnaire. There are several questionnaires, Berlin questionnaire, there are a lot of questionnaires. Commonly we use questionnaire or stop band questionnaire. We distribute this pamphlet to the OP patient by the secretary. They fill yes or no questions, so we can know, we derive this from the points we know that the clinical suspicion of whether the patient has sleep apnea or not. And Epworth Sleepiness Scale to assess the daytime sleepiness. The stop band questionnaire, we ask the patient about the following questions, whether yes or no. These are the scenarios. Stop band. Snoring. Do you snore loudly? Tiredness. Do you often feel tired, fatigued, or sleepy during the daytime? Observed apneas. Has anyone observed that you stop breathing or choke or gasp during sleep? High blood pressure. Do you have or are you being treated for high BP? BMI is your body mass index more than 35 kilogram per meter square. Age, are you older than 50 years? Neck circumference, is your neck circumference greater than 40 centimeter, that is 15.75 inches. Gender, are you male? Score 1 point for each positive response. Scoring interpretation 0 to 2 indicates low risk for obstructive sleep apnea. 3 or 4 intermediate risk. More than 5 is the high risk for developing the clinical suspicions of obstructive sleep apnea. Epworth Sleepiness Scale, this scale to assess the daytime excessive sleepiness. So in this Epworth Sleepiness Scale, there are some situations and chance of dosing. We have to put the points. So situation like sitting and reading, watching television, sitting inactive in a public place, for example, in a theater or meeting, as a passenger in a car for an hour without a break, lying down to rest in the afternoon, sitting and talking to someone, sitting quietly after lunch when you have had no alcohol, in a car while stopped in traffic. So we have to put the score like chance of dosing 0 to 3. So 0 means I would never dose. 1, slight chance of dosing. 2, moderate chance of dosing. 3, high chance of dosing. We have to put the score like 1 if score is 0 to 6, 2 if the score is 7 to 10, 3 if the score is 11 to 13, 4 if score is more than 14. The higher the score, higher the suspicious of the daytime sleepiness, which leads to the clinical suspicious of obstructive sleep apnea. Coming to the clinical examination, seeing the patient, majority we can diagnose to seeing the patient. Majority of the cause of obstructive sleep apnea, sleep disorder breathing is obesity. So obesity, usually we can pick up short neck, there is neck circumference size more than the 40 centimeter, facial abnormality to see any retro or migraugnathia, oral cavity in children and adult population, see the tonsils and the oral cavity examination, we can pick up whether the patient is having a difficult airway or not. And invariably, 30 to 40% of the patients of OSA have the high blood pressure. So this is the Mullen-Berty classification of oropharynx difficult airway assessment. You can see here, class 3 and 4 airway are a high-risk group to develop the perioperative complication due to the obstructive sleep apnea. Coming to the investigation, sleep study, polysomnograph is a gold standard. Polysomnography is a gold standard test to confirm the diagnosis of obstructive sleep apnea. Other investigation modalities are sleep endoscopy or nasopharyngoscopy or drug-induced endoscopy to help in assessing any anatomical abnormality in the nasopharynx, whether any correctable causes like any polyp or any turbinate hypertrophy before goes in a treatment. So we assess the upper airway by ENT surgeon. And sleep MRI or dynamic MRI to assess correctly where is it exactly the level of obstruction, whether it's a single level or multi-level, so that we can plan management for curative procedures like beltopharyngoplasty, coagulation technique, laser technique to treat and cure completely. The facial capillometry is an important test to find out whether the patient has retrognathia or micrognathia. This is important for the maxillofacial surgeons. Polysomnography is a gold standard test in polysomnography. We measure oral and nasal airflow, respiratory effort, pulse oximetry, 2-lead EKG, leg and chin EMG, electroaculography, and 2-lead EEG. From this polysomnography, we derive the metric value called AHI, apnea hypopnea index. That is, total number of apneas and hypopneas divided by the total sleep time in hours. Based on this AHI, we divide the severity into mild, moderate, severe. Mild AHI 5 to 15 per hour, moderate AHI 15 to 30 per hour. Severe means the apnea hypopnea index more than 30 per hour. If apnea hypopnea more than 30 within first 2 hours, we do a split polysomnography. This is a diagnostic and therapeutic study in a single night. There are 4 levels of sleep study. Level 1 and level 2 are in lab or in hospital polysomnography. Level 3 study is the portable study or home sleep test. So this study also very useful for the diagnosis of obstructive sleep apnea as per the American Academy of Sleep Medicine. Level 4 sleep study is just wearable devices like wristwatch and digital watches we can wear in the wrist and attach the simple fingerprint pulse oximeter. We can measure the oxygen level during sleep. This is the level 3 polygraphy. Level 3 sleep study, home sleep test monitoring. You can see the respiratory channel. We can attach like this. This is the report of level 3 polysomnography. We derive the value of apnea hypopnea index, respiratory disturbance index, apnea index, and oxygen desaturation index. And this is the graphic representation. This is the recordings of snoring, respiratory effort, pulse, and the saturation, etc. This is the level 2 polysomnography in the hospital setting. You can see EEG lead and EMG leads with the level 2 polysomnography apparatus. MRI scan is very useful for surgical candidates, those who are pushed for surgery. Before the surgery, you must assess where exactly the level of obstruction, whether is it a retropalatal or retroglossal or multi-level. Once diagnosed of obstructive sleep apnea, what are the treatment modality? The sleep disorder breathing treatment is a multidisciplinary approach. Chest physician, pulmonologist will lead the sleep disorder breathing treatment and they involve the ENT and head and neck surgeon because in pediatric VSA, the treatment of choice is adenotonsillectomy. Oral and maxillofacial surgeon, the role is important to cure completely by doing the maxillary mandibular advancement. Bariatric surgeon mainly for the bariatric procedures like gastric bypass, etc. In the case of morbid obesity, the BMI is more than 40. Medical treatment of sleep disorder breathing, general measures, you have to avoid alcohol, smoking, sedatives, and hypnotics. Weight loss is the paramount important. Morbid obese people, we have to send the patient for bariatric surgery. Specific measures to increase upper airway caliber, position therapy. In the case of mild, moderate cases, we tell the patient lie down in the lateral decubitus. Thereby, we can avoid the tongue fallback and reduce the upper airway narrowing. Thereby, we can prevent the choking, etc. Positive airway pressure is a gold standard treatment. PAP therapy, we have manual CPAP and bilevel system BiPAP and automatic CPAP. And we have oral appliances for retro and micrognathia. Positive airway pressure therapy. PAP therapy is the gold standard treatment for sleep disorder breathing. We have CPAP and bilevel PAP. Upper airway assessment before PAP therapy by ENT surgeon is very important for the better adherence of the PAP therapy and interface. This is the full face mask and CPAP. CPAP, continuous positive airway pressure, act as pneumatic splint for upper airway. As per the recommendation of American Sleep Academy, we have to wear at least 4 hours per night into 4 nights per week. The poor compliance due to claustrophobia, nasal obstruction, facial and nasal pain, dry eyes. We have to follow the patient every 3 to 4 months in 1 year and repeat polysomnography if there is significant weight loss or gain or major change in daytime symptoms. Dr. Colin Sullivan from Sydney, inventor of CPAP in 1980. This is, we call it as magic box, CPAP, magic box, first described in 1981 by Dr. Colin Sullivan in Sydney, Australia, in the Royal Prince Alfred Hospital, Sydney. Accepted in 1985 is a very good treatment modality for the obstructive sleep apnea and commercialized from the year of 1986. This is the intelligent CPAP, this auto CPAP we call it as the intelligent magic box. This is the nasal CPAP. This is the nasal insert and chin strap. This is very useful to prevent the open mouth breathing when you put the nasal pillow or nasal cannula, nasal pillows or nasal mask. This chin strap will help in relieving the mouth breathing. Different CPAP interfaces like nasal insert, nasal mask, and full face mask. There's various kinds of CPAP machines. Non-surgical management, oral appliances, mainly the mandibular advancement device, tongue retaining device. These are various mandibular repositioning devices. This is adjustable mandibular reposition devices prescribed by the oral and maxillofacial surgeon. Coming to the surgery in sleep disorder breathing, adenotonsillectomy in pediatric age group is the gold standard treatment. And in the case of middle age or young age people, those who are having mild to moderate disease of sleep disorder breathing, so we have to go for a upper airway surgery by sending the patient to ENT and get a neck surgeon. Maxillofacial advancement osteotomy are the procedures like oral appliances for retro and micrognathia. Bariatric surgery for morbidly obese with BMI is more than 40. This is a child presented with open mouth breathing and heavy snoring and daytime sleepiness, very poor performance in the school academics. So this patient underwent adenotonsillectomy. After the procedure, there was a heroic improvement in the school academics, etc. Surgical management, maxillary mandibular advancement, MMA, performed in conjunction with the oral surgeons. Maxillomandibular advancement osteotomy, this is the pictorial representation. We have to cut the mandible and forward. This will be very useful procedures. It's a one-time procedure, so complete cure for retro and micrognathia causing the obstructive sleep apnea. Bariatric surgery, BMI is more than 35 or 40, we will send the patient for the bariatric surgeon. In the bariatric surgery, the commonly performed procedures are gastric bypass and the no-sleep gastrectomy. To summarize, sleep disorder breathing is a common among the sleep disorders. The only thing is very much under-recognized, under-diagnosed, under-treated condition. The common symptomatology of sleep disorder breathing are snoring and excessive daytime sleepiness. So we differentiate whether simple snoring or sleep apnea snoring. Any patients with a habitual snoring, so we rule out by doing the gold standard test called polysomnography. Level 1 and level 2 polysomnography is a gold standard, and manual CPAP titration is a gold standard, and treatment modalities. Syndrome is that you all know very well. Metabolic syndrome, there are 4 components. Metabolic syndrome, syndrome X is diabetes mellitus, hypertension, dyslipidemia, obesity, we call it as syndrome X and metabolic syndrome, plus obstructive sleep apnea is a syndrome Z. Once you diagnose the sleep disorder breathing, treatment is multidisciplinary. Mainly we lead the team of sleep disorder breathing treatment modalities. Pulmonologists, we plays a major role. ENT surgeon plays a major role in curing the disease by removing the tonsils and adenoids, and so many pharyngoplastic procedures to cure the disease completely. And maxillofacial surgeon's role is very important, and bariatric surgery is very important, helpful for the morbid obese patient. CPAP is a gold standard, but the adherence and cost factors are the major concerns because the sleep study and CPAP is usually not covered by the insurance. So we, as a Chest Council of India, we recommend the policymakers and the insurance people to make the sleep study as well as the treatment modalities of CPAP or surgical surgery. So we include in that sleep apnea diagnosis and management. That way, so we can do more and more studies, more help to the patients. So with this, I conclude my talk. I thank you very much, Chest Council of India. I thank Chairman Trustees of CCI, Dr. N. Krishna sir, and Dr. Narender sir, CCI National President, Dr. Narender sir, CCI National General Secretary, Dr. Ravi Dosi sir, CCI Webinar Coordinator, Dr. Vijay Kumar Chennamchetty. So thank you all for this wonderful evening. Over to Dr. Vijay, moderator for the panel discussion. Thank you very much.
Jayaraman, it was wonderful. Okay, you have covered almost all key areas in your talk. Thank you for that brilliant presentation. There are good number of questions that have already we have received. Let me walk you through, the questions what we have here. So, Dr. Ajay, hi. So here is the question for you. Yes, Dr. Jayaraman has covered very good, but let me ask you how to memorize and how to, please tell us what is the complete spectrum of sleep disordered breathing and in what aspects that clinicians must, understand and then memorize this. You're muted. Please unmute yourself.
Good evening, everybody. Thank you, Dr. Krishna. Thank you, Dr. Vijay Kumar. Sleep disorder breathing is a very broad spectrum. It comprises of 5 major components. First is a primary snoring, which is probably most of Indian consider as a very innocent breathing. When people have a snoring, you can hear the sound of a snoring, but there is no oxygen drop or there is no arousal. So that's a primary snoring. The next serious condition or the next severity index of the spectrum is a UARS, upper airway resistance syndrome, when there is a little bit of a obstruction of a airway, but it doesn't really last for 10 seconds and it doesn't really lead to the complete apnea. So that is not a complete obstruction, but oxygen do drop significantly, not more than a 4% or 3%, which was the definition of American Academy of Sleep Medicine. So that's the next part of the spectrum is upper airway resistance syndrome. Then comes a mild OSA, moderate OSA, and severe OSA. As we all know, mild OSA is defined by the events of obstruction more than 5 to 15 per hour with the drop in oxygen. Moderate OSA when the events are more than 15 but less than 30 per hour in a upper airway obstruction. And severe OSA is when events are more than 30 per hour as an obstruction in upper airway. That's called severe obstructive airway disease. Some institutions do suggest that obesity hypoventilation syndrome is also part of this sleep disorder breathing. Yes, in that particular disease also, it happens during a sleep. There's a hypoventilation. There is a certain amount of sleep fragmentation. There's a certain amount of hypercarbia and hypoxia involved. But there's no apnea per se in a pure obesity hypoventilation syndrome. But yes, we can consider it as a sleep disorder breathing spectrum component. Thank you.
Thank you, Ajay. In our practice, just extending the same question, okay, we do come across, in few cases, there is an element of only REM-related obstructive sleep apnea. So if REM-related AHA is more than 30 or 40, okay, how do you classify such case? Because their overall AHA may be still somewhere around 7, 8, 9 kind of thing. But how do you take such cases?
Okay. While we report, we definitely mention in every report what is a AHI and what is a REM AHI. In our report since last 10 years, what we are dispatching, we do mention both the things. And as you said, there are certain cases where REM AHI is significantly higher and non-REM AHI is very less. We do mention separately in that particular report that if AHI is 5, the complete sleep AHI, and REM AHI is 69, then we do mention that it's a REM-related obstructive sleep apnea syndrome.
Thank you. Now, hi Shivani. Yeah. Does every snorer requires medical attention?
Yeah, so I think Dr. Jayaraman sir has very, elaborately discussed this in his talk also, that there are certain snorers who are not snoring every day. They only snore occasionally, which may be because of upper airway obstruction in terms of sinusitis or having a cold or a URI, or they may be snoring only on days that they have consumed alcohol or something like that. So this subset of population practically does not need a consultation with the doctor. However, of course, unless it is for their sinusitis or a URI. But for somebody who is actually snoring every day, has daytime symptoms in terms of excessive daytime sleepiness, has disturbed nighttime sleep, also has witnessed apneas, as the partner says. So this is the population which is actually very, very prone to have moderate to severe sleep apnea, and they certainly need to visit their doctor.
Thank you, Shivani. So what Dr. Shivani wants to communicate is, if they are primary snorers, only snoring as a problem, they may not require any medical attention. But if there are associated symptoms, make sure you visit your sleep specialist. Hi, Kripesh. Where are you? You're not able to see him here. Yeah, hi. Can we diagnose sleep disordered breathing just mere on history and clinical examination? Because we have seen in past 2 years, because of COVID pandemic, a lot of teleconsultations. Is this possible to just diagnose sleep disordered breathing based on teleconsultation? What is your take? Kripesh, over to you. You are muted, man.
First of all, I will wish everyone a happy World Sleep Day, and thanks this NS Krishna sir, CCI President, and also the CCI member for this nice CMA online CMA on eve of World Sleep Day. Diagnosing sleep apnea just based on history and clinical examination is important, but this is not absolutely possible because the common symptom of sleep disorder being like daytime sleepiness, daytime symptom like daytime sleepiness or fatigue, or nighttime symptom like snoring and witness apnea. If these are there, then probability of sleep disorder breathing goes high, and in that case, again, but for final confirmation, we need to do a polysomnography.
Yeah. Thank you for that input. But I'm sure when the patient is far away and then is calling you over phone or video consultation, I think to some extent we can diagnose sleep apnea.
There are actually,
as Dr. Jayaraman said very clearly, using stop bank questionnaire and Epworth sleepiness scale index. These kind of things we can do over telephone. We can inquire, and then we can send some WhatsApp forms and then let them fill it and then send them back. And I think we can do a fairly clinical diagnosis can be possible just based on teleconsultation. But to confirm, we need to have a polysomnogram. Thank you for that brilliant input. Hi, Jay.
Good evening. Yes, sir. Yes,
yeah,
sir.
you rocked this evening with your fantastic talk. That was absolutely phenomenal. Total appreciations on behalf of CCI.
Thank you.
And how to decide about need of sleep study for our audience sake? Please elaborate one more time.
Yeah. The obstructive sleep apnea, that is sleep disorder breathing spectrum, mainly the clinical diagnosis. We have a lot of questionnaire to ask whether the patient has sleep disorder breathing or not. Seeing the patient, majority 80% we can diagnose whether the patient has sleep apnea or not. We ask the leading question to the bed partner, whether snoring, daytime tiredness, choking, gasping, and all. So based on this, so clinical diagnosis, these are all the non-specific symptoms, snoring, daytime sleepiness, and all. So occurs in so many conditions. So we want to clinch the diagnosis. So we tell the patients to undergo the overnight, single night polysomnography to clinch the diagnosis of obstructive sleep apnea. So even though we are making the clinical diagnosis, obesity, etc., stop and questionnaire, correct? But this is not non-specific. Sometimes we mislead the thing. So for the confirmation sake, we tell the patient, educate the patient about the need of sleep study and do it in the overnight study, whichever the facilities available. In our setup, so we do a portable home sleep test. So in the patient home, we do the test and confirm the patient about whether the patient has a sleep apnea, obstructive sleep apnea or not. So this way we follow our clinical practice to diagnose the sleep study. Sleep study is another important test to confirm whether the patient has sleep disorder breathing or not. Yes.
Thank you. Thank you. What I do in my practice is, as soon as the pre-filled questionnaires, they will fill it up and then come back. If at all, if there is a lag of time, if the patient directly walks into my chamber, what I do is, whether they are snoring or not, first important, many a time they may deny snoring, even if they deny snoring, because the mild amount of snoring what these patients have, they may neglect, because okay, they don't think that, they assume that it's a snoring which is audible to the next room only is the problem causing snoring. That is the predominant perception in our patient population.
Yes.
But I don't consider. But what I do is I have a small thing. What I use in practice is whether they have short temper, excessive daytime sleepiness, and witnessed apneic spells. These are the three simple things. Okay, I remember as software engineer: short temper, witnessed apneic spells, and EDS. So these three, if they are there, most of the times, 90% of times, then we can conclude then and there itself that these are the possible candidates who are suffering from severe symptomatic sleep apnea, and then we must rule out. And thank you, Jay. And yes, we have kept our surgeons waited for the past 30 minutes. Thank you, my dear Srivatsa and then Vikas Agarwal, for joining us today on this lovely evening. We are looking forward for wonderful inputs from both of you. First, let me question. The question remains same for both of you. So what are the various kinds of patients that you come across in your hospitals for surgical management? Do you think enough awareness exists in the society? Over to Srivatsa, maxillofacial surgeon.
Sir, can you please repeat the question, sir?
The question is, what are the various kinds of patient that you come across in your hospital for surgical management? Do you think awareness, we believe awareness for sleep apnea is slowly rising up. Okay, a decade back, it was almost non-existent. Now people know that snoring is a pathological problem. And then my question to you is, do you think awareness for this surgical management exists in the society?
Good evening, one and all, for a wonderful opportunity. And I thank the organizing committee and everybody, including Dr. Jayaraman, for this opportunity. I would like to tell that dentistry and maxillofacial is still always a primitive condition compared to the general other conditions. The reason is because it is you people who have to basically you're supposed to tell the common people about these kind of conditions. So, for example, a joint problem comes, a lot of people think it's neuro, a lot of people think it's orthopedic, and then somebody has to tell it has to go to a maxillofacial surgery. Like that, in a day-to-day procedure, it is the role of a pulmonologist and the team to tell to which level of reference our intervention is necessary. For example, if there is going to be a maxillomandibular functional condition, then it has to be a appliance condition. If it is going to be a maxillomandibular skeletal condition, then the surgical procedure has to be needed. Then if it is going to be allied specialties like addressing the tonsil and the nasal, then our ENT consultants has to be done. Yes, of course, it is improved than before, much betterly, but still the contribution of the obstructive sleep apnea and the sleep is about 90% in the hands of the pulmonologist, and it is now coming much openly to other specialties.
Thank you, Srivatsa. Over to Vikas.
Yeah, very good evening to all of you, and my sincere thanks to the committee of the CCI. Now, you have asked two questions. What are the various kinds of patients we get in our clinic? So, being an ENT surgeon, people perceive snoring as a matter of nose. Actually, they feel that because the nose is blocked, so they are snoring. So, this is the commonest variety of patient which visit us, saying that he is snoring a lot, his nose remains blocked. And they also have a lot of nose blockers in the daytime, most of them. So this is the first variety, and they're ready to get their noses operated and they want to get rid of it. The second variety, which comes to me because I have been practicing as a sleep apnea surgeon for the last 12 years. So the second variety are the patients who are already diagnosed as a case of obstructive sleep apnea, and they have already been prescribed a CPAP. So when they come to me, they want to get rid of the CPAP. because they're either unable to use it for a long time. They say that we feel very fresh while this is on, but we are unable to use it for a long time. And in most of them, I find that the nose is blocked. So again, as I said, nose blockage is a very, very important reason. The third category of patients is that when the nose is, also free, but the base tongue is actually obstructing. That's a very small subset. But the major subset of the patients are when the nose is blocked and they either cannot use the CPAP or they do not want to use the CPAP. That's the time that they actually come to us. And a very, very big subset is that who just wants a spray to get cured. And obviously there's no answer to that. So awareness part, I think it is increasing, but as my colleague just said, Dr. Srivatsa, that it's you, the physicians, who is they have to tell that, yes, you can have sleep apnea, you have to do the sleep studies. And only when our intervention is required, like opening up the nose or say, removal of the tonsils, adenoids, or base of the tongue when it is falling, I believe our role comes much after yours, because patients generally come, are seen by the physicians first. So I think your role is very, very important, sir.
Because just extension of the same question, because at one point of time, probably I can say approximately in early 2010 or something, between 2010 to 2015 kind of thing, there was a time where a lot of ENT surgeons practiced aggressively UPPP. And then not much of results with the same surgery. The patients tend to recover with the symptoms. What is your take on it?
So, sir, if you allow me, I'll just like to share my screen for a few minutes.
Please go ahead.
So basically, the development which has happened in this field in the last 15 years is phenomenal. So as we do a CT scan for every patient to know whether his septum is deviated, turbinate is hypertrophic, he has got sinusitis or he has got adenoids, and correct that. This was happening before also. But the latest development which has happened in the field is of sleep endoscopy. So in the oropharynx, where the major collapse happens, we figure out which area of the anatomy is actually obstructing, and that too under BIS monitoring. So it's a very, very controlled procedure where you actually figure out which area is working. And if you see this experiment where I'm putting a CPAP, making a hole into it, and then doing a drug-induced sleep endoscopy. So this actually shows. This is wonderful. Now see, when we are switching off the CPAP, the palate is totally falling. Okay. This is the apnea without. Now switch on the CPAP. Switch on the CPAP. We just saw that the moment you switch on the CPAP with the flow of air, the soft palate is kept open. This is actually how CPAP works. On the soft palate, because it's a tube, it can, and we see what kind of a collapse is happening and how we can correct it. But the same thing on the base tongue. So you saw that the CPAP can throw open the soft palate, but it cannot actually lift the huge base tongue. So this is a major development in knowing where is the problem: nose, palate, base tongue, and the epiglottis. So nose and base tongue and the epiglottis cannot be tackled with the CPAP. The soft palate can be, which is more than 75 to 80%. So in those cases, CPAP works, but in cases where the nose is blocked, where the base tongue is obstructing, epiglottis is falling, it does not work. And that's where we can actually remove that obstruction by plasma, which has only come in this country, say around, I started using it in 2009. So from then around 13 years, it has been there. So, and we actually remove that part of the base tongue, soft palate, whatever is there. And this is the kind of result we can get. And, actually we can help those patients who are otherwise unable to be, held by the CPAP. So this is the development. Therefore, and in surgery also, even on the palatal surgery, there are so many variations depending on what kind of collapse the patient has to do the surgery. That's why the improvements have happened in every field, sir, including surgical.
So thank you, Vikas. So, my dear friends, please note this point. When the nose is blocked, please send to ENT surgeon. When the throat is blocked, please first refer to chest physician. And if the patient is not improving despite a CPAP, then probably that time we need to consider whether the surgeons have a role to pitch in at this moment or not. So my next question goes to Dr. Ajay. So yes, we do prescribe a lot of time sleep studies to our patients. So what kind of preparation that patients and then the technician will adopt before performing the sleep study, Ajay?
Dr. Vijay Kumar?
Yeah, hi.
Perfect. Hi again. Sleep study is not a very commonly known procedure for a general crowd. It's not like a blood collection. So we require to elaborate the need of a sleep study, probably even a cost of a sleep study, because it's not a very cheap study. It's not something which people go and get it done without really understanding why they are paying money for. So the technicalities of sleep study, what is the overview of what we are suspecting, like a obstructive sleep apnea, the complications of untreated obstructive sleep apnea. So there's certain amount of a counseling is required before ordering a sleep study. Now let's come to the base part of your question. What is the preparation of a sleep study? If everything is done, the orientation for a sleep study, orientation for an overview of obstructive sleep apnea is given. Now, on the day of a sleep study preparation, I have made certain pamphlet, which we always give it to our patient, and we say it also before we schedule his appointment for a sleep study. That reads out something like this. Try to follow your regular routine on a day of a sleep study as much as possible. So there's nothing like a major travel happen on the day of sleep study. There's not a major sleep disturbance happen a day prior to your sleep study, because that can affect the next day's sleep. Avoid napping in the afternoon. That's very important, because if person has slept in the afternoon, then it would be really difficult for us to get a good data on the night of a sleep study. Eliminate use of tea, coffee, Coca-Cola after lunch, because we all know caffeine is going to hamper our sleep pattern. Shower, but do not use oil or hair gel, because it can affect our transmission of signals through electrodes. But do clean your scalp from a dirt and oil. Remove nail paint from one of the index finger of both the arms, both the hands, because we have a pulse oximeter which goes there. And we all know that it works on a photospectrometry. So if there's a nail paint there, then it can affect the signal of the pulse oximeter. Wear comfortable clothes, whatever you usually wear while you go to sleep. We even encourage people to carry their pillow and bed sheet also, if they are so habituated to sleep with that only. We always tell them to finish off their dinner about 1.5 hours prior to their scheduled sleep lab reporting, because we all know that gastric emptying takes about 1.5 hours to 2 hours to finish off. And if you have undigested food in your stomach, then it's really difficult for you to go to sleep peacefully. That's basically normal instructions. We always ask people to take their regular medication, including their sleeping pills, if they are taking anything prior hand. Just tell us, we have already taken that particular history in our drug history, which drug they take, which molecule. We all know that every molecule has certain amount of impact on a sleep pattern and sleep spindles. So we make note of that particular drug, and it helps us while reporting and analyzing the sleep study report. That's all for time being.
Yeah, Ajay, excellent. Do you recommend, if the patient is a regular boozer, okay, do you recommend him to continue to have his couple of pegs on the day of sleep study as well?
I really don't know to answer this particular question in a scientific way, but then probably I won't. The reason is, I know it could impact their sleep pattern, because if they are habituated to take a booze and then sleep, then I know it could impact their sleep pattern. But we take a note of that. What happens is basically they get a little bit of a more latency in the sleep onset, nothing more, but
Right.
they eventually sleep. And what I'm interested is basically to look at all the phases of a sleep rather than one particular part of a sleep.
But
And it becomes really practically difficult to allow people to enter into hospital area when they're boozed.
excellent summary. Excellent.
Vijay Kumar sir,
Yeah, please.
it's again another common question because a lot of patients tell, why should I go get hospitalized in a hospital, do a sleep study? Why can't I get it done in my house and then go to the doctor? Can you please clarify on this?
Yeah, Ajay, over to you.
I guess it's a common question. Why hospital and why not home? I guess we can answer this particular question in a due course of our this particular presentation where we are talking about home sleep study and in-lab study. Probably that's a better.
Absolutely. Then I'll come back to you, Ajay, little later. Srivatsa. Right. So, Jay, here is your turn. Where can you please, let us know what are the various pros and cons of home sleep study, the extension of what Dr. Srivatsa has asked.
Yeah. Home sleep study nowadays we are doing very, several patients, their preference, because home sleep test is a very cheap and better mode of analyzing the sleeping pattern, breathing pattern to diagnose the sleep apnea. So the advantage is we can send the technician to the patient home and attach all the gadgets, and technician give the instructions and he'll go. So patient in his own bedroom lie down and sleep. So without any hospital atmosphere, so without any fear of the infection and all, so patient can lie down and sleep well. So during the home sleep study, we are doing a home monitoring because it's a monetary benefit. This is a very cheap test, number one, and patient the bedroom itself, we can do the test. These two is a very important one, and the disadvantages like this one. Main thing is we rarely miss the complex apneas. And rarely we may get a false negative report in home sleep test. So as per the recommendation of American Sleep Academy, the level 3, other home sleep test is more than sufficient to diagnose the obstructive sleep apnea. If you have any complex apneas or if you have any false negative report in home sleep test monitoring, then you have to go for the in-lab or in-hospital polysomnography.
So what is happening in Indian practice? So there are a lot of these private labs which are doing polygraphy as well. And they say that, yes, that's enough for documenting evidence of sleep apnea. What is your comments on it? Level 4 study.
Level 4 study, actually, we are measuring the just oximeter, any desaturation during the sleep time. So this is mainly for the screening purposes we are doing. Any level 4 study showing the desaturation during night time. So we have to do the home sleep test or in-lab test to confirm 100%. So polysomnography is always a gold standard. There is no doubt at all. Home sleep test, because the non-availability of the level 1 or level 2 studies in all the places, this is one of the indications for the home sleep study. So this is the
Dr. Ajay, you want to add any comments here?
I just want to clarify a few things here. When we say level 1 and level 2, there's only one difference, that level 1 is an attended study and level 2 is an unattended study with EEG montage. So when we say in-lab level 1, we say level 1 study, which is patient is there in a hospital for that particular night with the full EEG montage with video assistance, if there's a video there, and which is fully attended by a sleep technologist, a trained sleep technologist. And level 2 is the device is more or less same with is EEG montage, which goes to patient's home, but which is unattended. So technician goes, puts out all the sensors, including EEG, so sleep sensors, but he leaves a home and he collects the module next day morning. The only hitch I have, because I don't want to talk about level 3 and level 4, because level 3 where they don't use sleep sensors and level 4 obviously only saturation is measured. I don't consider there are sleep studies because there is no sleep measurement happening. So they are practically literally not sleep studies. They are more of a polygraphies where a major other signal sensors are documented. Okay, so the So the difficulty with the level 2 study, that's a unattended home sleep study, is we can lose the data. Because when patients sleep with his spontaneous behavior, one of the sensors can pop out, his oxygen saturation can drop. And all these things are very important when I sit across to score the study and interpret the study. We don't do auto scoring, we do manual scoring. So we actually don't rely on a software to detect the stage of sleep for us. And it becomes really difficult for us when there's a loss of data between the sleep, when it is not attended at home, to score a study, give an exact severity, and offer even a treatment plan. So even if I do home sleep study, what I recommend is attended home sleep study with the online laptop, which we practice in Mumbai, where we do in-lab studies in a hospital, and we do home sleep study with an extended wire, which patient sleeps in his bedroom, his own comfort zone, but my technician stays in a hall or living room with a long wire and a laptop in his hand. So it's an online attended non-video level 1 study at home.
Thank you, Ajay, for that wonderful clarification. And Shivani, do you want to compare and contrast the advantages and difficulties of in-lab sleep study?
Yeah, sure.
What do you practice in your setup?
See, preferably the first choice that we give to the patient, the first option is certainly an in-lab sleep study, which is a level 1, fully recorded. We have a night vision camera as well. So it is a completely recorded sleep study that is the complete polysomnography that we offer. However, there are certain times that the patient is not really willing to do that. So that then, a level 2 study is the second option, but then we do not have a supervised level 2 study. We have a home study. It is absolutely level 2, that the technician goes, installs the lab, hooks on the patient to the lab, and then he leaves and then goes and collects it in the morning. So, however, having said that, even in an in-lab study, I think there are its own challenges. There are times that patients are not able to sleep in a new environment, are not able to sleep well. Certain times there will also be disturbances apart from that from the hospital environment per se. So that certainly is a added on challenge. However, having said that, even for home sleep studies, like my colleagues have discussed, that for people who have complex sleep problems, it is not advisable to do a home sleep study at whether it is a polygraphy or a polysomnography, unless it is completely supervised, because then we are bound to, in a polygraphy, also miss arousals, which is very, very important when we are actually scoring respiratory disturbance index, that is the RDI, which is also a very sensitive parameter to score sleep disturbances. So certainly my first choice is a level 1 study, but then there are times that we tend to, have to repeat it because the patient has practically not had his normal sleep on the first night.
Right. Thank you, Shivani. And Dr. Kripesh, we have seen both advantages and disadvantages of in-lab study and then home study. In our practical day-to-day life, how to choose right study for which patient, and what is your take on it?
Again, we have seen the advantage and disadvantages of home sleep study and in-lab studies. So actually, if we see the patient from the history and other things, if we see that patient is having only OSA and other diseases are not likely, and is good enough for a home sleep study, so most of the patients we can diagnose at a home sleep study, because we can reduce the cost of treatment. And also more with the recent advances in recording, we got a good data in home sleep study. But if you see the patient has comorbid condition and other things are there, and we suspect any other disease that is beyond OSA also, then periodically movement or central sleep or other things, then or other complications, then in-lab study is preferred one.
Thank you. Over to our surgical colleagues. what are the various practical difficulties that you encounter? You have a patient, okay, whom you are suspecting sleep apnea or sleep disordered breathing, and then you have to suggest sleep studies to them. Generally, yes, 90% of times they come with, from pulmonologist or, other physician references. And Dr. Vikas, what are the challenges that you face to convince that your patient population that you need a good quality sleep study?
As I said, sir, earlier, that most of the patients believe that their nose is blocked and that's where they're having, sleep apnea. So we have to convince them that it's not only the nose, the collapse happens in the throat. How many times, what is your oxygen saturation? Where is the problem? Everything has to be understood. So the first step is whether you have sleep apnea or not, you have to undergo a sleep study. Then the second problem comes, like Ajay said, that people want to get it done at their home. And in the home sleep study, obviously, you cannot diagnose everything. A lot of things are missed. So to convince them to get admitted to the hospital and get a level 1 study is again a very important challenge, because they say, no, we'll not be able to sleep in a new environment, and all those things are there. So many a times we are actually we have to satisfy ourselves by doing a level 3 study, which if it is showing that the AHI is pretty high, say 30, 40, then it confirms that he has got a severe disease. The numbers are obviously not very real. But many times, as my previous colleague said, that sometimes it's a false negative study, and the study comes negative, and then you're stuck, because they say, no, we do not have sleep apnea. Now the study is negative. Then again, you have to tell them, now you again now do the level 1 study. This is the major challenge. And again, availability of a level 1 study, cost, and the problems of sleeping in a foreign place, all these things are there. So we have to possibly find some better solution. I actually learned from Ajay that his person actually goes with that extended wire. It's a very good idea. Actually, we can incorporate it in our practice, that at the patient's home, it's all attended and almost a level 1.
Right.
Yeah, Dr. Vijay Kumar.
Yes,
Sir, it is actually what my previous speaker told was right, but it is more primitive to us, because when they come to problem as a nose, and then you talk about sleep, it's fine. But in our clinic, when they come normally and they talk about snoring, and it's like generally a complaint between husband and wife complaining on each other about sleeping not properly. So the best way to convince them for sleep clinic for them is like, don't spend money on weight reduction clinic, go to sleep clinic, you'll reduce weight. So they obviously keep running to Jayaraman, sir.
Thank you, Srivatsa. Right. Over to Ajay for what do you prefer, manual scoring versus auto scoring? Yes, you have answered partly. What is the most appropriate way in your experience? Because in India, because of lack of quality sleep specialists, okay, probably most of them are depending on manual scoring. Your take, please, Ajay.
I'm a little biased with this particular approach, because I'll give you a small history if you allow me 30 seconds.
Please.
I became a chest physician something in 2001. Till 2010, I was doing exactly same thing which most of the India is doing now. I used to ask some vendor to get a level 3 study at a patient's home, and he used to give me a ready-made data of a sleep study, seemingly sleep study. No sleep parameters were recorded in that particular level 3. It was auto study, it was auto reported, and the 2 figures I used to see. What is a nadir oxygen, lowest oxygen, and what is the AHI? And then the solution was auto study, auto reporting, and then auto CPAP. So everything is auto. So there was nothing like there's nothing like a doctor coming into the picture. There's nothing like a medical science coming into the picture. I used to wonder myself what I am doing here, because I could see in other specialties that all ECGs machines have an inbuilt software to read a ECG. All EEGs have an inbuilt software of read or score EEG. But nobody prefers that. Everybody makes sure that they manually reports, they interprets the data, this waveform. Why pulmonologists are depending on some vendors, some technician who knows only 2 things: hook up, get the things out, put it into USB stick into the software and get a printed report, which is invariably without any signature, even today. Because it happens that nobody wants to own that particular report. Nobody wants to take ownership of that particular, because nobody has validated that report. I used to feel really, really uncomfortable for myself. Then I got this opportunity to get myself training in a MRE sleep. I got a American Academy of Sleep Medicine fellowship, got selected. Went there, saw that, and then I wanted to translate that whole thing in a Mumbai. It took a Herculean effort for me to convince my hospital to get a level 1 sleep study with a video EEG, but we got it done. In last 8 years, 2012 till 2009 years, 10 years now, we have trained close to 5 technicians. We have 1 RPGST. We have a good sleep scorer. We do manual scoring. And then we did some internal checkups about what is the difference between manual scoring and auto scoring as well. Like we do something like a auto scoring of every one study. And then we expect our scorer, trained scorer, to manually score it. And we see the difference between 2 scoring patterns. Now, I am not the only person who did that. American Academy of Sleep Study has a lot of these type of a pilot project happen since last 40 years, that what is better, auto or manual. Now, I'll tell you my experience. I don't want to quote any paper. Most of the scoring softwares, which are auto scoring software, which are inbuilt into either MLA's software or Philips software. I know 2 labs. I don't really work with any other company's lab. I work with MLA's, that's a MLA software, and Philips software. Wake is most of them reported as a REM. REM is most of the time reported as a wake. Spindles are definitely picked up very well, but then hypopneas and apneas at times are not picked up well. The AHI is a very different variation in auto scoring and manual scoring. So it's always better. Now, I'm on an education committee of American Academy of Sleep Medicine since last 1 year. So we formulate a lot of educational material which gets distributed to all the fellows and members all across the globe. We have this particular thing going on last week, that whatever our guidelines are, how validated and how relevant they are in today's age, because there are new softwares are coming. Just for the sake of this particular question, I would be a part of a AI and sleep medicine education committee of American Academy of Sleep Medicine from this June onwards. That's a 1 year of committee member participation. So AI is coming, artificial intelligence is coming in a sleep medicine in a big way. I'm interested into all these things, so I volunteer for this particular job. It's a little wee hours. I have to be online to discuss it, but yes, there's a place for a technology to interpret sleep studies, but they always say whatever technology do, it has to be validated by manual scoring afterwards. Alone auto scoring is not accepted by anybody all across the globe.
Thank you. Thank you for the detailed description about the need of manual scoring when compared to auto scoring. So may I request now Kripesh to, yes, how do you motivate your patients to get the some amount of consciousness about getting tested and getting evaluated for sleep disordered breathing? What complications that you expect of untreated sleep disordered breathing, Kripesh?
Yes, thank you, sir. Motivating a patient for sleep study is little difficult until and unless we give time and we do not explain them properly the reason of sleep study, and most importantly, what is the sleep apnea, and we have to explain that what is the complication of sleep apnea they can develop if that is not treated early. Because many patients just came with snoring and fatigue or excessive daytime sleepiness, and with that symptom, and if we ask them to go for a sleep study, many a time they said they do not realize the value of the sleep study actually. Then at that time we have to give her time and explain them properly that what the suspicion that we have we suspect that patient is having sleep apnea. We have to explain the things, and then we have to say that if this is not treated, then it may lead to certain complication. So I have made a small for 2-page write-up on OSA and its complication, and I give the patient after explaining them and ask them to read it. And after that, usually the patient goes for sleep study. Then we have to explain properly the complication of OSA remain untreated, and major complication we can see either cardiometabolic complication, so metabolic complication like diabetes, or other complications like your uncontrolled blood pressure, or raising hypercholesterolemia, or other problem like your cardiac diseases like atrial fibrillation or your heart attack can occur. All this we have to well explain, and also other complications like stroke or risk of your accident when patient have excessive daytime sleepiness. All this we have to explain to the patient, and that will improve your overall acceptance of sleep study and also awareness about the sleep disorder.
Thank you, Kripesh. Essentially, you would love to counsel them in detail, hand over the leaflet, and tell them about the complications if they don't get treated properly. Over to Shivani. May I ask you about, yes, Dr. Ajay has detailed very well about the manual scoring versus auto scoring. What is your take on titration, whether you prefer, in-lab or home auto titration, Shivani, and in your practice, and then what is the evidence says?
Thank you, Vijay, for that question. So if you ask me my personal opinion, I think I am all for in-lab study and in-lab titration. I have always advocated manual titration so that I know what's happening, and I know that the patient has had REM sleep, he's had enough REM sleep in supine position while we are doing the titration. And so I'm all for a complete titration study, which is again a level 1 study with a manual titration. But however, I think in the current scenario, given, the COVID scene, a lot of people, like everybody, I think agrees that not a lot of people want to come to the hospital, stay overnight for a sleep study. So I think in today's day and age, rather than no titration and just giving somebody a auto CPAP, it may just be a good idea to give the patient a auto titration at home maybe, and see how they do. With the same thing, we can also, of course, do a level 2 study with a auto PAP device titration, and then see how they do. Because, of course, that reduces the cost, which is a major concern when it comes to the Indian population. And also, as we are talking about evidence, I have come across a lot of studies recently where they do advocate auto titration because, the cost is much less. There is high acceptance from the patient, and there is less chances of failure. So there is this huge study done in the UK by Cross et al., which actually prefers, their endpoint was to compare manual versus auto titration. And they actually talk about auto titration being better in terms of acceptance and less failures. And of course, the cost is much less.
Thank you. Thank you, Shivani. Jayaraman, over to Jayaraman. So, when you want to select some PAP device, so how do you select PAP device in your patient population, and what are the various devices available in the market? Jay, are you there?
Yeah, Vijay. Yeah, I'm there.
Meanwhile, you are seeing patients, man. I don't agree. Quickly, you are seeing patients between questions, huh? Right.
PAP devices, mainly the posterior pressure. There are a lot of PAP devices are available for the sleep apnea management. So commonly we use the manual CPAP machine, and we have a auto-adjusted CPAP machine, and we have a bi-level CPAP machine, and we have the adaptive cerebral ventilation. There are a lot of advanced modes of CPAP therapies are available. So first come to the bi-level support. So indications of bi-level support is very clear that the overlap syndrome, obstructive sleep apnea with the severe COPD respiratory failure type 2, so directly will go for the bi-level support, both inspiratory and expiratory setup. So we prescribe the bi-level support in the case of type 2 respiratory failure and the overlap syndrome. Or the CPAP, patients requiring high amount of continuous positive pressure, high pressure, then we'll go for the bi-level support. And majorly in our practice, we prescribe after the titration, we prescribe automatic CPAP. Because in the case of auto-adjusted CPAP, the patient comfort and the sleep quality, everything will be better in an automatic CPAP, auto-adjusted CPAP. In the auto-adjusted CPAP, the patient, some of the patients, they prefer to use the humidifier for the better comfort and dryness, to avoid dryness and all. So this is the common modality we practice. So auto CPAP is the one of the best modality we prescribe in our practice comfort. And if the patient has a high pressure requirement, we'll go for the bi-level support or any other comorbid conditions like OSA or obesity hyperventilation with the type 2 respiratory failure patient, we prescribe the bi-level support. Yes, Vijay.
Thank you, Jay. Dr.
Actually, quickly, Vijay, I'd like to quickly add that per se, when we talk about literature, I think auto CPAP had some very specific indications, which actually included positional sleep apnea, REM sleep apnea, then people who are actually occasional alcoholics, and which especially, cases where the pressure requirements were varied from night to night or from position to position or from sleep stage to sleep stage. So these were basically, I think, the specific indications for auto CPAP per se.
Shivani, thank you.
So, Jay has brought some important issues like, I would love to take the opinion of Dr. Vikas here. Post-surgery, patient have some residual excessive daytime sleepiness, Dr. Vikas.
Yeah.
So, and he is finding difficult to use CPAP. Probably, he has, when we redo study, we got to know that, he has got severe apnea persisting. So what are the various things that you would guide in these patients to make him more comfortable to use these PAP devices? Do you recommend anything particular?
Let's understand your question first. Post-surgery, you are saying, no?
Surgery is over, or else, naive patient who has come to you, but there are some nasal issues. As you previously said, there may be some mild polyps, mild nasal stuffiness. These kind of patients, or they pose common challenge that they deny usage of, they don't feel very comfortable in using these devices. So when they don't need exactly the surgery, so what do you do? Or post-surgery, when they have these kind of symptoms, how do you manage?
So most commonly, these patients have a lot of allergic rhinitis, and their turbinates are swollen, obviously, which cannot be taken care of by the surgery also. So though we do the CT scan, try to figure out where is the problem, but most of these patients who are on allergic rhinitis, if they have given a proper nasal spray, steroid-based intranasal corticosteroids, which is a topical thing to apply, they have that inhibition that steroid we should not use. Then we have to convince that this is only topical. And intranasal corticosteroid, in my practice, has been a boon for all these patients, because the moment their allergies come down, their postnasal drips come down, which actually gets into the pharynx, the nasopharynx, and that causes that viscosity increase, and therefore the sleep apnea is increased. So one aspect of the practice is liberal use of intranasal corticosteroid spray. And then if it is after surgery, if the patient has still not done well, then we repeat the drug-induced sleep endoscopy, and we figure out that the surgery was possibly done incompletely, incorrectly. It's a very common thing, because there are not many sleep apnea surgeons in the country. We are trying to train as many surgeons as possible. We are learning from our mistakes, and we are training others. So repeat DICE figures out if there's a problem in the base tongue which has not been addressed, or the epiglottis is collapsing, then we correct that. So nose as well as the hypopharynx, I believe, are the most common areas that we figure out.
Thank you. Srivatsa, what is your take?
Our take is the last take. So what we do is, usually the mandibular maxillary component, we advance it to the maximum of 12 mm. There can be a setback of 2 mm, but the 10 mm, they are very comfortable. 99.9% of our patients have never complained, because the appliance as well as the orthognathic surgeries up to the age of 58 to 72 we do, they are usually very, very happy. And some patients are very happy, the appearances, the smaller jaw getting corrected, the neck muscle fold getting corrected. So there is no age for beautification. They are very happy with that.
Thank you. Thank you, Sri. And over to Ajay. Ajay, what are the various devices, various companies that you do practice? That do you prescribe in your practice? And I want to hear from you. Off late, for the past 3-4 years, we are hearing to a lot of these cost-effective Chinese devices, PAP devices, which are available for 10,000, 12,000 kind of thing. What is your take on it?
I usually prefer to stick with the reputed ones.
Right.
Do you want me to say aloud a company name, which is probably is not a good idea in this particular platform? But
Okay.
probably 2 or 3 reputed ones which have a track record of manufacturing devices for last 40 years.
Right.
Because I believe machine purchase is one-time thing, but patient do require support and service backup for long duration.
Right.
It's not only machine, it's accessories which require certain amount of updatation and at a time certain amount of change. So your
For
vendor.
example, if you see Ajay, I'm sorry, I'm
Yeah, go ahead.
interfering. If you see, recently we have had a very major issue with callback of all the PAP devices from.
I'm coming to that.
Please go ahead.
So basically, you require somebody who is a reliable vendor, and vendor is as important as the manufacturing company. So I genuinely want to believe that a company which is a good reputed manufacturing company which has a global presence. I want to tell you that if I give you percentage wise weightage of a sale of a CPAP devices all over the world, out of 100 devices sold all across the globe, 52 come from one company. Close to 43 come from another company which has certain amount of a difficulty in last 2 years because of some technical issue in their PAP devices. So they are rolling back all the devices all across the globe, and they will probably replace all the devices in next 9 months. So that company is out of question since last 2 years because FDA has asked them not to sell any company till the time this issue is settled. So now we are stuck with, or rather now narrowed down with only 2 companies. One company which has a major share of 52% all across the globe, which is reliable company, which is pioneer in a CPAP manufacturing, which has a phenomenal good service support all across the India. Most of the vendors are comfortable giving those services because your vendor is basically a person who can give you home to home services, and we Indians love home to home services. We don't want anything to go and deposit into the service station or something like that. So I prefer a good manufacturer with their track record, good quality machines, service backup, and a software backup. And probably Chinese companies is something which, okay, I haven't used it any, but what I heard, I'll tell you, most of these companies do launch their products in country like India where we are price conscious. But after selling certain amount of models, they just shut their shop. So patients don't really find anybody to go and ask their replacements or problem solving. They don't even provide the data card download, which is a major important part of our OPD follow-ups of our sleep study patients. So it becomes really difficult to manage this patient. Yeah, I agree for those people who want to just take it as a point of occurrence study, asked, machine sold, and tata bye bye. But we are sleep physicians, so we don't take that particular approach. We treat sleep apnea patient the way endocrinologists treat diabetes patient, the way cardiologists treat their hypertension patient. We have a regular follow-up, 3 monthly regular follow-up, data card download, we readjust the pressure, we do troubleshooting, we actually handle their issues at our clinic level. And only when this is a technical service issue, then only technical team from a manufacturer come into the play. So I definitely promote good manufacturing track record, a good vendor which has a global presence and good reputation.
So, my dear audience, please note it. Okay, cost is not only one issue. Okay.
In fact, it becomes expensive. It becomes expensive
Yes.
because unused machine, improper machine becomes a liability in your home. And this market is not a very good in a secondary market. Nobody wants to repurchase your machine. Nobody takes it back.
So please be cautious while prescribing. Do prescribe only the standard company models, okay, that saves your patient's health, that takes care of your patient health in a proper manner, and then service as well. And what are the various, coming to Kripesh, what are the various common complaints that you do see after prescribing PAP therapy, and how do you troubleshoot them? And one by one, I'll go the same question to all the physicians here. Kripesh first. Over to Shivani.
Yeah. So,
Oh, okay.
sorry, Dr. Kripesh, go ahead.
Yeah, I just forgot to unmute myself. Actually, there are certain.
You are practicing while doing webinar, okay? And Kripesh also started seeing patients. This is not at all completely acceptable. Kripesh, please pay some attention. Patients will be there, okay? I know you are a busy practitioner. Please go ahead.
No, yeah, sir. Actually, there are certain troubleshooting that we found once the patient started the CPAP or after we prescribed the CPAP therapy. So these effects are related to different categories in terms of interface related problems, or we can categorize in terms of a pressure related or others problem like. So interface problem related like the mask issues or the pressure from the mask or ill-fitting mask or air leakage, and then your skin ulceration or irritation, and then rhinorrhea are the complication that we can see with the interface related problem. Then pressure related, there may be a pressure dryness in the mouth or aerophagia or stomach upset because of the more aerophagy, and all this problem we can see. Then other issues like we can see like claustrophobia or like your CPAP induced central severe apnea. So these are the complications that we can see once the patient start using a CPAP in our clinical practice.
Yes, Shivani, how to manage such issues?
Yeah, so I primarily interface related issues. I tell all my patients, and I make sure when my technician is doing the titration, I make sure that they give first thing that they do is a mask fitting. So mask fitting not only involves adequate size of the mask, but also what mask is comfortable and adequate for each patient. So we have very tailor-made protocol, tailor-made therapy. This is that my technicians have standalone instructions that they have to spend time with the patient to make sure that the mask before starting the titration is perfect fit for the patient and the patient is comfortable with that particular mask. So we keep these variety of masks and we make the patient try every mask. Of course, we sanitize and sterilize them from time to time and after every use. So that's the first thing that we do. Coming to the pressure source, I think that problem has pretty much come under control with these newer masks, which are very soft, which have this gel lining. Unless the patient is tying it really tightly, I think it is pretty much under control and unheard of in today's day and age. And unless the patient is tying it really tightly, in which case we just need to check and recheck. Also, when it comes to problems like aerophagia, I think that patient is practically mouth breathing a lot, and that is why they're facing aerophagia, in which case, like Dr. Jayaraman said, we can probably use a nasal mask with a chin strap. So that, of course, and as far as drying is concerned, usually because we live in an area which has extremely cold winters, I always actually advise them to take a heated humidifier along with the equipment, because the winters here can get really unbearable.
Dr. Ajay, you want to add anything?
Not really, but I guess most of the points are covered. The only thing is it's not always interference. It's basically they don't want to use a PAP. Simple. So they can give you n number of excuses to not use a PAP. Anyway, the protocol goes very refined way in our setup. After sleep study, they use a machine for 5 days. Even though we have a titration values in our hand, we set those values into that machine and we allow people to use this particular machine for 5 days at home. I always say it's a man-machine syncing. Dosti hone do. Dosti jab tak nahi hogi, don't buy it. because if they buy it and if they don't use it, it's a wastage of money. And as I told you in last question, the secondary market of PAP devices is absolutely not mature in this particular country. So unless until they start using it, I don't advise them to buy the machine. Now, there are only two criteria which I look for at the end of a fifth day of home CPAP machine trial with pressure already installed into the machine. One is a adequate amount of hours they used it. My cutoff is 6.5. I know American Academy of Sleep Medicine says 4 hours. My cutoff is 6.5 hours every night. And second thing is whether their AHI has come down somewhere close to 5. 7 is acceptable, 3 is acceptable, 1 is I will take it with a pinch of salt because it's probably over titrated. So the first thing is those two things. And when these two numbers come in my hand with the data card download, it becomes very easy for person to convince that he's using it right way. And the machine is giving him benefit also, because his 114 AHI has come down to 7. He's using it for 6.5 hours, which his own action gives him confidence that he can use it for longer duration. Then comes certain problems of interface. Now I want to add something here. Most of the machine which give you leakage report more than 35 liters or 40 liters. Now I'll tell you what these particular machines do. They sense every obstruction or resistance inside mask as an obstruction in an airway, and they keep on increasing the pressure. So there's a nasal obstruction, they keep on increasing the pressure. If there's a pharyngeal edema, they keep on increasing the pressure. If there's leakage through the lining of the mask because of an improper mask shape or mask size choice, as Dr. Shivani was telling me, the size of mask is very important. We have a scale to actually determine the small, medium, and large size of the mask. We have different type of mask in an Indian setup. I don't know about pediatric thing, but in an adult mask arena, there are ample of choices available. Frankly, there is no dearth of choices. Now there are full face masks which doesn't cover nose. It only covers nostrils and the face. So it doesn't give you any claustrophobic sensation. You can put your glasses on your eyes and still use the CPAP without really getting disturbed. And I ask them to use it when they are not sleeping, when they are looking at the television screen. It's a basically desensitization of CPAP machine. When they are not sleeping, they should use a CPAP machine. Put it on one particular point which probably we missed on the discussion is there's a feature called ramp. There's a ramp feature in every machine, so which allows your machine to start at certain point and allow gradually to increase the pressure. So sudden increase in the pressure can be troublesome for most of the patient. But if my machine starts at 4 and if I require 12 pressure at the end of 30 minutes, it becomes a gradual incremental pressure from 4 to 12, and it becomes very easy for most of patients to be comfortable. And as we discussed in one of the slides in Dr. Heron, there are flex technology, there is the EPR technology. That particular things can help people to have machines convenient for them. So basically mask, proper choice of machine, setting up a machine with the humidifier, RAM technology, certain amount of intranasal steroids, as Vikas told me, to get rid of their nasal congestion. All these things help people to accept CPAP in their life comfortably. So that's all.
Thank you, Ajay. Thank you, Ajay. In the interest of time, I will take to next question. Shivani, please throw your some enlighten us on MSLT, and here Dr. Prasanna Kumar is asking this question from Bangalore. He is also asking on comment on sleep paralysis significance and clinical implications, and he also requested you to comment on REM latency.
Yeah, sure. So first, talking about MSLT, it's a diagnostic test that we do practically for narcolepsy. So basically, all it is measuring is the tendency of a patient to go into sleep immediately after he has actually had a good night's sleep. So the first prerequisite for doing a MSLT is doing a overnight polysomnography, wherein the patient actually has had a good night's sleep with adequate REM sleep and has had non-significant no significant sleep apnea per se, or AHI of less than 5. So this is the first criteria that has to be met before you go ahead to do a MSLT. While we are doing a MSLT, we practically on the next morning, the immediately next morning after the polysomnography, we actually give the patient 2-hourly opportunities of 20 minutes each. These are called napping opportunities, wherein we do actually hook him up again to the entire sleep lab. And what we are basically looking at his tendency to not just nap, but also during that nap, if he gets a nap, what is his REM latency? That is the period wherein right from the moment that he falls asleep to the onset of the first epoch of REM sleep. So that's practically, we give 4 such napping opportunities at the interval of 2 hours, lasting 20 minutes each to a patient to look for REM latency in these periods. So basically, that's what we are looking at. So a REM latency of, a patient gets REM sleep in more than 2 such napping opportunities is highly suggestive of excessive daytime sleepiness, which does actually point towards narcolepsy. So that's what basically we are looking at.
Yeah. Thank you. Thank you, Shivani, for that elaborative explanation. Here we have some questions from Dr. Kiran Balani. He is asking if a person is on regular anxiolytic like alprazolam or lonazepam, okay, should he or she take it before PSG? We have answered that, Dr. Kiran. Yes, patient must continue the same amount of anxiolytics before doing the sleep study. Dr. Sudhir is asking about how to decide quality of sleep. Dr. Jayaraman, can you please comment on that?
Yeah. Regarding the quality of sleep, so we need to attach the EEG leads, whether the patient is in REM related or non-REM related. So we need to have the level 1 and level 2 study to diagnose very clearly whether the patient has the quality of sleep, whether any disturbed sleep and all. So the level 1 polysomnography is one of the important tool to give the idea about whether the patient is having a good sleep or any disturbed sleep and all. So for that, the patient has to undergo the fully attended level 1 polysomnography. So any other point you can add, Jay?
Yeah, that's good enough. Dr. Praveen Bhatt is asking, we keep talking about American Academy, any Indian Academy guidelines, especially on studies. That's what he is asking. Dr. Praveen, yes, we have Indian Sleep Disorder Association, okay, which has got a very good core body and which has released a lot of guidelines on management of sleep disordered breathing. And all this data is available free of cost. We can download and then use it. My good friend from Pune, Dr. Toke, is asking, any role of pharmacotherapy in obstructive sleep apnea? Over to Ajay.
Drug treatment for obstructive sleep apnea? Answer is no.
So, probably when they are not able to use CPAP in such scenario, is there any drugs that can modify the REM sleep or something like that?
Nothing like I can say and vouch it for. That's why I said no. I know there are certain experimental drugs which are tried,
Right.
but nothing I can really vouch and give as an advice, professional advice to anybody.
Right. So
I'd like to add something here that, of course, like Dr. Ajay correctly said, there are a lot of drugs. One of them studied was a cannabinoid derivative, that was Dramamine, which there was a study done in 73 subjects, which actually showed not complete, abolition of sleep apnea, but a significant reduction in the AHI when, these patients were studied with only drug therapy. Also, when we talk about pharmacotherapy, I think I would just like to add that modafinil actually has some value wherein there is a complete resolution of AHI, but patients still continue to have daytime symptoms like excessive daytime sleepiness or sleep inertia, there in particularly modafinil certainly is helpful.
Thank you. Thank you, Shivani, for that addition there. So here Dr. Ravi Dosi is posted. He said that there are 1,000+ logins so far. That's a wonderful thing on the evening of World Sleep Day. Kudos to CCI efforts and then all your stalwarts participation in the program. And we do come across a lot of patients referred from our surgical colleagues and anesthesia colleagues to give pre-op clearance from pulmonary clearance for general anesthesia and then some surgical procedures. May I ask Dr. Kripesh to comment on what are the intricacies that we have to look into it, and then what should, and I also request Ajay to comment after Kripesh, what kind of clearance that we should give on consultation paper for these patients who are suffering from sleep disordered breathing.
Yeah, a very important question, surgical purpose. And there is also definite guideline for this also. So there are two categories of patient will be there. One who is already known OSA patient and who is already using a CPAP. So for this group of patient, we have to continue the CPAP in a preoperatively way and also in a post-operative cases. Then again, in a suspected patient of OSA where somebody suspect in a clinical but is not already diagnosed yet, and he is likely to go for a surgery under general anesthesia, then we have to do a evaluation properly, and then we have to for confirmation in a elective surgery we can wait for some time and we can do a proper polysomnography and diagnostic testing and make a diagnosis, and then accordingly we can plan a CPAP for our treatment preoperatively as well as in postoperatively. And most important in this group of patients is the postoperative monitoring, because they can have certain postoperative complications than a non-OSA patient, like the effect of general anesthesia may be more. They may have a prolonged recovery time in a recovery period, and then post-operative hypoxia can be more persistent and prolonged in this group of patients. So these are the simple summary of this overall title.
Dr. Ajay, do you recommend in such patients when they are extubating, do you recommend probably usage of CPAP or BiPAP while extubating in the time of recovery from anesthesia? What do you suggest?
Yes. The ICU backup is definitely recommended for these patients who have a high propensity of having obstructive sleep apnea. Whether they are diagnosed, then it's a well good. We have a diagnosis in our hand. We have a titration pressures in our hand. But if, as Dr. Kripesh said, the second group of patients where we don't really have a diagnosis in our hand and surgery is important, urgent, we can't really wait for a sleep study to happen and get the values on a paper, then we definitely want to get that particular patient delayed extubation, observation inside ICU, attempt NIV titration, don't allow extubation till the time anesthesia dose effect is completely worn off, give a good pain management, because that's very important for these particular people. If there's a upper abdominal surgery and their pain is tremendous, they try to not use their diaphragm effectively. They have a lower respiratory, lower lobes atelectasis, which really hampers their hypoxia, which give rise to hypercarbia. And probably that those patients you require little close monitoring for 48 hours even after surgery. And as Dr. Kripesh said, there are definitely, it's a preferable that they should get a polysomnography done before surgery. But in a hospital setup, whether we are tertiary care setup where it is not really practical every time we go ahead with the surgery because it's a life-saving or limb-saving, but then we have to be very cautious in a post-operative period. And that's all. There's a guideline of American Academy of Sleep Medicine, what drugs to be used for anesthesia, what drugs cannot be used for anesthesia. Everything is there in a place. We can always share that particular thing to you, because there are certain medicines which should not be used. Short-acting are preferable, long-acting require more monitoring. Hemodynamics are to be taken care of because obstructive sleep apnea changes a lot of cardiorespiratory dynamics inside the body. So all these things are very important. So basically the underline is Don't ignore these particular patient like a normal patients after anesthesia. Be vigilant with them for next 48 hours.
Thank you, Ajay. Jayaraman,
Yeah, yes. Vijay.
what are the medico-legal aspects of daytime drowsiness, and how do you see if a driver, example, if a chauffeur comes to you, he works for Tamil Nadu RTC, and then he comes to you and he have a diagnosis of severe obstructive sleep apnea. Do you recommend that to the road transport corporation that this guy is unfit for driving, or do you recommend that if he continues to use the PAP therapy, he will be fit for driving? What is your take on it?
Yeah. In general, these type of patients, driver with sleep apnea patients.
Even we do come across, there are reports that, pilots, they do take nap while in the cockpit.
Yeah. Driving is one of the risky profession. Any patients with these kind of obstructive sleep apnea, they're not on proper management, weight is overweight, and other comorbid conditions, means definitely we say no. So unfit for that driving and all. If the patient is no other comorbid conditions, not morbid obesity, and is taking a regular CPAP treatment, and he is coming for regular checkup, then we'll give the fitness to drive. Because if medical legal aspect, so we have come across a lot of patients with the road traffic accidents, all because of the lack of sleep. Drivers predominantly we are seeing because of the main culprit behind is the driver not taking proper treatment. In our country, so pre-employment, that means before driving license, we're not checking properly like European countries and all. So any driver in this high-risk profession, so we need to have a thorough examinations, and if the patient is having these kind of risky obstructive sleep apnea is very severe, obesity, so better we I don't know what the guideline says very clearly, because these are the patients involved in the road traffic accident causing a lot of mortality. So medical aspect clearly says no. So unfit for this kind of a risky job like driving or pilot and all.
Ajay, do you want to add anything regarding particularly
India
in compare and contrast with West?
India doesn't have any guideline on a paper, but US definitely has a yearly review of commercial drivers and pilots every year. They have a PhDs done, even if they are not symptomatic. They get their PhDs done every year. Now, important issue here is the daytime drowsiness of these drivers and pilots. Now, I'm adding a little bit to Dr. Jayaraman's answer. Person is diagnosed case of a moderate or severe obstructive sleep apnea. But if he's taking his CPAP regularly, we have his data card download subsequently or every month, which is absolutely under control, less than 5. He doesn't have a daytime drowsiness. His Epworth sleepiness score is less than 10. He's fit to continue his professional job. So there are two parameters. Adequate treatment with the adequate pressures, ESS less than 10, and third thing is he doesn't have a daytime drowsiness. He can continue to do his professional job. On a paper, we give that particular certificates to airline authority as well as people who wants commercial licenses in this particular country.
Thank you. And there are some other questions which are on obesity hypoventilation syndrome here from various audience. I want to skip in the interest of time because we have 6 minutes more. Shivani, can you please comment on what are the non-respiratory but uncommon indications of sleep study?
Sure. So I think that's an excellent question because that's often overlooked. So I think the non-respiratory symptoms special, I think the most common that I do not practice, but is a common indication of sleep study, especially children with parasomnias, then people with limb movement disorders like periodic limb movement syndrome or restless leg syndrome. I think those are the common ones that I know. And of course, like we've discussed, the MSLT and the multiple wakefulness latency test are two where in a sleep study, a night prior is mandatory before you go ahead with these tests. So these are the ones that I know. My colleagues, if they can add any on this.
So again, I'm sorry, in the interest of time. So I want to bring my surgical colleagues here.
Dr. Vijay,
Yeah,
Dr. Vijay,
please.
just one line.
Yeah.
This particular question, basically, I want to say one line: resistant hypertension and unexplained severe pulmonary artery hypertension. These two conditions, you should do PSG, because most of the time these two conditions have a undiagnosed hidden sleep apnea as a background. These are non-respiratory. They don't come to us. They come to our colleagues, cardiologists, physicians. And unless until you pinpoint on those two conditions, resistant hypertension and unexplained, I'm saying unexplained. If there is no comorbid chronic lung disease, unexplained severe PH, there is a definitely background sleep apnea happening there. Get a PhD done.
I want you to comment here on, again, generally Western statistics says the BMI of 40 and then 30 plus kind of thing. But in India, we do come across, normal behavior. In fact, underweight people also, they tend to have obstructive sleep apnea and sleep disordered breathing. What is your comment, Ajay?
Absolutely right. We Southeast Asian have this particular small distance between our chin and the thing. Vikas knows it far more than anybody else. And maxillofacial surgery, they know our ethnicity makes us preponed with the obstructive sleep apnea. That's one thing. Second thing, we generally have a central obesity. Our arms are thin, our legs are thin, but we have small amount of fat in a central portion. That's enough for our throat wall to go ahead and tongue to fall back and obstruct the airways. So garden variety of Pickwickian syndrome is basically low-lying fruits. Being a sleep physician, I should be trained enough, my eyes should be trained enough to see even those people who are not really coming as a classical picture, but we should still offer them a proper diagnosis and management.
Keep a very, very low threshold to suspect sleep apnea.
Absolutely.
In patients who are either typically presenting or there may be atypical presentation most of the times in Indian scenario. Please watchful, my dear friends. Okay.
Vijay Kumar, one of the statistics shows in Mumbai that 16% people have potential risk of high risk of obstructive sleep apnea at any point of a time. Now, I just want to tell you, 16% people in Mumbai don't have a cold at a time. So it's that common. 16% people don't even have a rhinorrhea at a one point of a time. It's very common. It's very common. We keep low suspects of indication.
So before closing this session, I want to have opinions of our surgeons, both Srivatsa and Vikas. Practical treatment options for mild obstructive sleep apnea when there is surgery must be considered. So in what situations do you consider the surgical management, even the patient is having a mild obstructive sleep apnea? Your comments?
Yeah, if the patient is overweight, if the patient is uncomfortable with your appliances like a CPAP or anything, and the patient is not able to carry the routine, the patient has early morning sicknesses. So these patients, we ask them to compulsorily to undergo a surgery so that you'll see a much better setback of getting better actually. The maxillomandibular advancement or the setback is going to give you a lot of advantages. Sometimes we might even add procedures with the lip as well as the tongue for the betterment of the airway.
So what is the lowest age recommendations that you recommend these surgeries, Dr. Srivatsa?
Anybody who has finished the growth spurt. Like a boy can grow from 11 to 14 and a girl from 9 to 13. Right. Anybody who has finished the growth spurt, a 17-year-old obese boy who's going to do a first year MBBS or engineering, who's unable to breathe, it's better to be advisable.
Thank you. Because you want to add anything?
Yeah, so sir, very small children have very frequently enlarged adenoids and tonsils. So we recommend removal of adenoid tonsils in small children. The patients who have got a grossly deviated septum, it's a daycare procedure. You can do it in the morning, patient can go in the evening. And so in fact, barbed laryngoplasty, we perform some barbed sutures surgery on the soft palate. It's again
almost along the pre-word of the soft palate.
So this is how we put barbed sutures in the soft palate to prevent them from falling. for
Now,
mild and
what
moderate
this will
sleep,
do, it
sleep
will not
apnea.
let this off.
So this is how
Where I
you
had
put
come
the
out.
suture. So I just wanted to show this. So they are very small option, daycare option. They can come in the morning and they go back by the evening, especially people who are not obese, especially people who are not old. So young people with mild and to moderate sleep apnea are the patients who anyway will not tolerate a CPAP for life. So those are the patients that we are really targeting to, and those are what the NOSA guidelines as well. So we target those patients to give them a relief from their snoring and sleep apnea.
Thank you, Vikas and Srivatsa. And last one sentence conclusion from each of the panelists here. First, Dr. Jayaraman.
Yeah, sleep apnea is a very common clinical condition, but in practical, this is a very much under-recognized, under-diagnosed condition. We need to have a lot of education awareness program to all the general public, including our own doctors' population. The gold standard test is level 1 polysomnography, manual titration, and the treatment is the multimodality. We have to involve the ENT surgeon, maxillofacial surgeon, and the bariatric surgeon for the morbid obesity. So this is take on this. And regarding the insurance cover, CPAP and the sleep study, so we tell the insurance people and policy makers to include this for the betterment of the sleep apnea diagnosis and management.
Right. Shivani.
Yeah, I think Sir has summed it up really well. And I think, like Dr. Ajay had earlier said, that we need to keep a very low threshold of suspicion, because I think there are Indian studies which show that from 19 to 25% of patients who are admitted for any reason, for in-hospital patients, do suffer from sleep apnea. So that's almost 1/4 to 1/5 of the population in the hospitals, which is actually a huge number. So, and I think, like Sir has summed it up really well, that we need to have insurance covered. Insurance need to accept and recognize this as a disorder, especially because it has so many associated fatal comorbidities. So I think it's extremely important.
Ajay, please.
I would like to ask all specialties, span specialties of medicine, to include few key questions about quality of sleep of their patients and help them to unmask their sleep troubles. Because the moment they understand they have a sleep trouble, then the road is easy. Then you know whom to contact. They know how to go about it. If you're not aware about your own sleep troubles, when your snoring becomes peaceful sleep, it's a jealousy for most people who don't get a sleep, then the problem remains in a bedroom. Problem has to come out of a bedroom. Then there are enough people to help, frankly.
Right. Kripesh, your comments?
Yeah,
Final comment.
actually we need the awareness regarding sleep disorder among the patient and also among the physicians. And India also need a qualified to deal with this sleep disorder breeding. This problem is huge, but awareness is very less.
Dr. Srivatsa.
Before COVID, blood investigation was very expensive, they felt. Now it's mandatory. Like that, one day or other, chest physician's opinion is going to be mandatory for any surgery. So I pray for the further, and I just want to tell in this place is that Dr. Jayaraman is my brother-in-law. He is my second eldest husband, and he's always been guiding light for me. Thank you once again for the opportunity.
Thank you, sir.
Dr. Vikas.
So, sir, I would say that everybody has said everything is already said. I would only say that upper airway resistance syndrome is actually much commoner than sleep apnea. So, like Ajay said, we have to include questions on getting up tired and being irritated. These questions in the nose block. 50% of the population has got deviated septum. 25% have got allergic rhinitis. What else are we looking for? So these questions, if we are able to include in the questionnaire of general physicians, family physicians, consulting physicians, I think a lot of patients, would be picked up, and they will not have to go through resistance, hypertension, and every other thing that we have talked in the last, say, 2 hours. So that question, possibly the physician community can help to get into the questionnaire of the physicians.
Vijay.
Yeah, please, Ajay.
There's one thing. We started this particular session with one question. What is the spectrum of a sleep disorder breathing?
Yeah.
Now I come to this particular thing. Vikas said upper airway resistance syndrome is a very important entity. Now, when we have a diagnosis after sleep study that this is not sleep apnea, this is upper airway resistance syndrome, or this is a mild OSA which doesn't cross 15 ka magical number of AHI. Now, most of these particular patients, the story ends there. Now, I'll tell you from my last 10 years of experience, keep following these particular patients. They eventually step the ladder of UARS to mild to moderate to severe. And when they lose the follow-up with the sleep medicine physician, because one sleep study done in 2012, it was UARS, nothing was there. And 2021, he comes to me with a severe AHI of 115. Both studies are technically right. Both studies were scored manually. I don't have any doubt about quality of study. The person has not changed his lifestyle. He keep on increasing his weight. He keep on doing the same stuff again and again. His disease progress over a period of time. So I always say, it's easy to treat moderate and severe sleep apnea. It's a difficult to keep a follow-up of URS and mild OSA. That's your basically the important sleep physician job is.
Absolutely agree with you. Absolutely agree with you. I cannot agree more. See, in the interest of time, my conclusion remarks are, thank you CCI for this wonderful webinar on the evening of World Sleeps Day. Yes, the theme here is quality sleep, which will result in sound mind and a happy world. Pranayama is very, very important in maintenance of homeostasis. Our Sanatana Dharma has said time and again, nocturnal pranayama, which is ensured with PAP therapy, will keep you hale and healthy if you are suffering from sleep disordered breathing. My dear friends, my dear colleagues, please keep a very, very low threshold to suspect sleep apnea or sleep disordered breathing and ensure your treatment you can pick at the very early point of time so that you treat your patients properly and to give them a perfect homeostasis. And remember, management of sleep disordered breathing is purely scientific. Okay. And
Yes.
let's practice sleep disordered breathing scientifically with evidence and experience-based medicine from stalwarts. And this effort from CCI is to bring out awareness among physicians across India. I'm sure we have done our job very well. It's your job to early identify these spectrum of disorders and treat appropriately. A quality sleep is essential in each individual, and it is a need of the hour to make our nation and then globe a healthier one. Next week, soon we are going to cover other disorders of sleep like insomnia and circadian rhythm disorders. Stay tuned to Thursday and Friday evenings
Vijay Kumar sir.
of CCI. Thank you. Good night, one and all.
Thank you.
Thank you.
Thank you, Vikas. Thank you, sir. Thank you,
Thank you,
Ajay.
sir. Very nice meeting all of you.
Very
Thank you,
Ajay?
Srivatsa. Nice.
Okay.
Hi, Vikas.
So we must